Good evening, everyone. I would like to thank you all for taking out your precious time from your busy schedule. This webinar is organized by Banai, Behavioural and Neurosciences Academy of India. Banai is a not-for-profit organization formed in 2012 and has organized more than 200 plus programs nationally and internationally. Focus of Banai is to provide contemporary cutting edge on behavioral neuroscience. Banai is formed and runs under the guidance and chairmanship of Dr. E. Mohandas. Banai welcomes everyone and anyone who is interested to join. It gives me immense pleasure to introduce Dr. Amrit Pattajoshi as the moderator for today's webinar. Thank you, Dr. Amrit, for accepting to be the moderator for the webinar.
Sure.
Dr. Amrit Pattajoshi is a professor and head of Department of Psychiatry at High Tech Medical College and chief consultant psychiatrist at AMRI Hospital and Healing Touch, Bhubaneswar. Dr. Amrit is a leading psychiatrist from Bhubaneswar, rendering professional help in overall mental health with key skills areas in mood disorder, anxiety substance, child psychiatry, and sexual disorders. Dr. Amrit Pattajoshi is also a direct council member of the Indian Psychiatric Society. I would now request Dr. Amrit to take over and start the session proceedings. Over to you, Dr. Amrit Pattajoshi.
Thank you so much. So I would thank the Banai group for inviting me as a moderator. We have brilliant topics, top-notch speakers, and our chairpersons are absolutely the best in the business. So I have been given the responsibility and to introduce the chairpersons. Next slide, please. Yeah, Dr. Rajiv Gupta, sir. He's a senior consultant psychiatrist at Manas Hospital, Ludhiana. Sir did his graduation from Medical College Jammu and post-graduation in psychiatry from PGI Chandigarh. He served as professor of psychiatry in Guru Ramdas Medical College Amritsar and Dayanand Medical College Ludhiana for more than 20 years. He has authored 2 books and various research papers in national and international journals. A monthly journal, Meditrack, is being published by Dr. Gupta from past 20 years. Apart from all his academic achievements, whenever you meet him in a conference, he'll give his tips. He'll ask you certain questions about practice, how to improve it, how to use technology. Sir is a brilliant mentor. Thank you, sir. Next slide, please. Dr. Debasis Basu, sir. He's a professor and head in the Department of Psychiatry, PGIMR Chandigarh, where he's involved in psychiatric service, postgraduate psychiatric teaching, research, and administration. He's an academician par excellence and psychiatric teacher with more than 300 scholarly publications. 300. Dr. Basu has received many awards at national and international levels. Some of these are, there are lots and lots, but then we are just naming few of them. NIDA Invest International Research Fellowship from NIDA USA, NHS International Fellowship from NHS UK, Honorary Fellow of the World's Association of Social Psychiatry, the Tilak Venkoba Rao Award from ICMR. He has won the Marfatia, the Bhagat Award, PPA from the IPS, Balint Award, GC Boral, NND Oration Award from the Indian IASP. His major areas of interest are addiction psychiatry, dual diagnosis, and social psychiatry. Sir, I welcome the chairperson for today's session and I hand over the session to them. Thank you, sir.
Good afternoon, everybody. I'm thankful to Banai for this great opportunity. So we have 2 contemporary great topics of drug addiction, the street drug circa 2021 and management of cocaine dependence. See, being in addiction practice, particularly in Punjab, the challenges are, so number one, the youngsters coming with the newer drugs, and as a clinician, a great number of times you're not aware, even by the lab testing, other methods, what kind of the drugs the particular person is taking. So clinically, once you're managing those patients, you are number of times clinically unaware. So regarding the diagnostics and regarding the management plan also, we are not very clear because every day the new drugs are coming. So I think both the topics are important topics, and second, regarding the management of the cocaine dependence, till date, the FDA has not approved any particular medicine which can be specifically used for the cocaine dependence. So let us hope both the speakers they bring their best and make all of us much more aware about the street drugs and the management of the cocaine dependence. Thank you.
Okay, I think it's my pleasure now to the first speaker, please. If you can share the screen.
So I hope it's visible now.
Is somebody sharing the screen of the?
So I have shared the screen, sir.
Speaker? Yeah, right.
It is not audible.
So you are in mute mode. Sir, unmute yourself, sir. Basu, sir.
Sorry. Yeah. Okay. Right. Yeah. I think now I'm unmuted.
Sir.
So, a pleasure to introduce the first speaker today is Dr. Dr. Ashwin is senior, completed his MD from PGI Chandigarh in 2000, and he has also completed his PGDME from the National Law School, Bangalore, in the year 2016. His main areas of interest are substance dependence, mental health and policy, psychiatry, and advocacy. He has held numerous posts in various organizations. That is the formal introduction, but informally, I must add a sentence here. It fills me with pleasure and pride to say that Dr. Ashwin Mohan has been my yeah, and so he's an alumni of PGI Chandigarh, and he has done all of us proud by his consistent advocacy for patients with addictive disorders. And I'm very happy for him to be a speaker in this important topic today. So that is about the first speaker. May I have the slide of the second, please? Dr. Debashish Ray. Yeah, Dr. Debashish Ray is a senior consultant psychiatrist associated with MedStar Clinics, Apollo Gleneagles, AMRI, Apollo Clinic and Hospital, Ruby General Hospital, all in Kolkata. He's a member of the International Research Committee of the International Society of Bipolar Disorders and a founder member of the Society of Bipolar Disorder India. He has several national and international publications and sessions and has chaired various scientific sessions in India and abroad. Again, on a personal note, if I may add a sentence or two, Devashish is almost like my younger brother. We are both Devashishis, and I have known him ever since our school days. We happen both come from the same school, which is St. Lawrence High School. He was 1 year junior to me, in fact, mate of my younger brother. So we have known him for last, I don't know how many years, for decades. And it's a pleasure to see him in this forum today. And of course, he's an excellent speaker, as you'll all very soon find out. So we have two very fine, very knowledgeable, and very eloquent speakers, both of which who are close to my heart. So I'm looking forward, as I'm sure you all are, to a knowledge-filled evening today. Thank you. Thank you.
Thank you. Amita, should I start or?
So you can start, sir.
Okay. Thank you so much to Banai for inviting me as a speaker, and I'm very, very fortunate, and thank you, sir, for those kind words. Very fortunate to have Dr. Basu and Dr. Rajiv Gupta as the chairpersons today. Together, they have almost, I think, about 60 years of experience in addiction psychiatry, and extremely happy to for them to be the chairpersons today, especially also because they are also from my alma mater, PGI. So I think we are a little late, so I'll better start. Just share my screen. Am I audible, and is the screen visible?
Yes, yes,
Yes, thank you so much.
certainly.
So the topic allotted to me today is street drugs circa 2021. And actually, in a sense, it's a really difficult topic to to speak on the allotted time, which is about 20 minutes, because there are a huge and staggering number of drugs which are there now available all across the world. So, so what exactly is a street drug? Is it a drug just sold on the streets versus which is something which is sold in a pharmacy or hospital? Is it a drug which is sold on a prescription or a non-prescription drug? Okay. Uh, a drug which is used only for therapeutic purposes or recreational purposes, which is controlled or non-controlled, legal or illegal, a drug which is available in a dosage form or an adulterated or an unchecked drug. So what exactly is a street drug? So let's get some definitions. A drug actually is a term of varied usage. In medicine, it refers to any substance with the potential to prevent or cure disease or enhance physical or mental well-being. In pharmacology, it means any chemical agent that alters a biochemical physiological process. Of course, we know all of this as doctors. But in the context of international drug control, a drug means any of the substances in the schedules of the Schedule 1 and Schedule 2 of the 1961 Convention, whether natural or synthetic. And there it's called a narcotic drug. While a psychotropic substance is any chemical agent affecting the mind or mental processes. And in the context of international drug control, psychotropic substance means any substance, natural or synthetic, or any new natural material in the other schedules of the 1971 Convention. This is important because we'll see that the number of newer drugs which are coming are there to avoid being under the control of these two conventions. That is the 1961 Convention and the 1971 Convention. Google tells me that the street drug is sold illegally and used for its mood-altering, stimulant, and sedative effects. So basically anything, it's basically a recreational drug sold illegally, not on prescription in any particular place. So getting these definitions out, the scope of today's talk is I'll only give an overview of various types of street drugs and what are the trends of drug use, the challenges and issues regarding these drugs. It is virtually impossible to talk of each drug or each class of drugs because they are huge and staggering. And obviously, this excludes any clinical presentation, signs and symptoms of any of these drug use or drug dependence, the pharmacokinetics and pharmacodynamics, management issues, and issues related to legality, scheduling, and of course, we are also not going to talk about the legal drugs like alcohol and tobacco. So who hasn't seen Breaking Bad and all the other Netflix series? Probably Breaking Bad is one of the series which has brought the psychoactive substances to the forefront and shows it's fictionalized, of course, but of course it also highlights the reality where chemists and other rogue elements are able to easily make drugs right in their backyard. It is how simple that it is. And unfortunately, That is what is happening now. And also, there are reams and reams written on the opioid epidemic in the US about the overdose deaths, about the problems related to prescription drugs, opioids specifically, especially in the US and some of the other countries in the world. And of course, the headlines, which we keep hearing and seeing after every few days and weeks, really, which have highlighted the real dangers of these drugs, the so-called street drugs. So we all know about the broad classification, and this is just it's a simple classification, not based on any particular scientific methodology. So we have cannabis and what are called as SCRAs, synthetic cannabis receptor agonists. We have opium, opiates, and opioids. We have coca and cocaine, stimulants, amphetamine-like stimulants, and these include many other stimulants which are there. CNS depressants like ketamine and GHB. And of course, we have hallucinogens like magic mushrooms. So we have the well-established drugs, heroin, cocaine. We have some of the club drugs or designer drugs, which constitute a subset of some of these established drugs, which are a broader class. And of course, we have novel psychoactive substances, which are a relatively smaller subset of these established drugs. And again, this is for simple understanding. Coming to opioids, in the mid 1990s, what happened was, how did this American opioid epidemic start? The American Pain Society said that pain should be the vital fifth sign after blood pressure, temperature, pulse, and respiratory rate. And they said that pain was being treated inadequately and inhuman way, and many people who deserve that their pain to be treated were not being adequately given enough medication. And this led to a huge increase in pain prescriptions. And then the rest is history, as they say. There is a clear but not complete overlap between prescription opioid abuse and heroin use. And the balance shifted towards treatment of pain with less regard given for contributing to development of abuse and risk of overdose death. So a lot of prescriptions were given for indicated conditions, non-indicated conditions, increase in the number of prescriptions of opioids, mainly synthetic opioids, hydrocodone, oxycodone, fentanyl and its analogs, methadone, and of course, there were co-ingestions of other CNS drugs, which were mainly responsible for the overdose deaths. That is, you could find a combination of drugs or polysubstance use in those patients when their toxicology reports were generated. So what happened? Gradually, over a period of time, patients dependent on prescription pills shifted to heroin when the pills availability started reducing over a period of time due to a huge interest and regulations over control of these pills. And then they shifted to heroin and fentanyl as the supply of pills reduced. There was an increase in counterfeit hydrocodone and oxycodone. As usual, traffickers saw a business opportunity, and then they started producing fake pills. And mainly these contained fentanyl. They were mixed with cocaine, heroin, and prescription opioids in various combinations. These are the names of some of the common fentanyl analogs which are there. No need to go into their names. China, as we know, in the forefront today for all the wrong reasons. Even in this particular epidemic, Chinese laboratories today produce some of the world's illicit fentanyl and continue to do so. Interestingly, you should know that Janssen, the founder of Janssen Pharmaceuticals, we use so many of their medications, was the inventor of fentanyl in way back in 1959, 60 years back almost. But when fentanyl was first synthesized in 1959, nobody could have predicted that it would eventually create so much of suffering. No one could have known it would become more common as cheap liquor in America's inner cities. That's how cheap it is, and much more deadly, or that anyone with an internet connection could have it sent to his or her door. Coming to new novel psychoactive substances known by this acronym NPS. Now, what are they actually? Substances of abuse, either in a pure form or a preparation, that are not controlled by the 1961 Convention on Narcotic Drugs or the 1971 Convention of Psychotropic Substances, but which may pose as a public health threat. So importantly, it is to understand that these substances are not controlled by these conventions, which were way back in 61 and 1971. Therefore, they are specifically designed to avoid legal control. New does not necessarily mean new inventions. These drugs have been present for decades, some of them actually, and but have only recently arrived in the drug markets. They mimic the psychoactive effects of established illicit drugs like MDMA and cocaine while avoiding legal sanctions to enable their sale by street vendors. And in the last couple of decades, only NPS has come to the forefront and have highlighted their dangers. In fact, the European drug market saw an alarming escalation of the number, potential, and availability of and harms of these drugs. In 2014, 101 drugs were detected. As of 2019 December, 950 substances have been reported to the UNODC on NPS, 950 and counting. In Europe, by the end of 2018, more than 730 new psychoactive substances were monitored, 55 of which were detected for the first time in 2018. That's how fast they are made. These substances make up a broad range of drugs, as I said earlier, synthetic cannabinoids, stimulants, opioids, and benzodiazepines. In fact, actually, even a smaller structural modification to existing illicit drugs could place the modified substance out of legal control, but not significant enough to change the basic pharmacology or the desired psychoactive effects. So what happens is that they change the structure a bit. And since legal controls are very, very strict as to which substances can be controlled and which are not, these substances then escape legal sanctions. So this graph shows the number of drugs right from 2005 to 2018. Shows the number of new psychoactive substances and a peak of 101 substances in 2014. Fortunately, it has now leveled down and the number of substances are coming down to about 55 in 2018. Although the new number of substances have come down, the penetration is as much as it was earlier. So this is a rough categorization of classification of these drugs. So they mimic the effects of established drugs. Just to summarize, they have lower cost and higher purity. They have differing chemical properties which determine the onset, duration of psychoactive effect, potency, and toxicity. And like we have second generation antipsychotics and third generation antipsychotics or antidepressants and such, even the NPS have got a second or third or even fourth generation which are being developed. So as with any chemical, any drug, any therapeutic or non-therapeutic drug, even NPS have newer generations coming up all the time. And importantly, they are rapid and dynamic. Some of these NPS just go out of the market within a few days to few weeks to few months, depending on various factors. And they suddenly reappear, new ones come with change structures, or the old ones make a comeback after a few years. So this is how dynamic and rapid is this particular NPS market, which makes it even more difficult to detect these drugs. SCRAs, which are called actually synthetic cannabinoid receptor agonists. And they are again a diverse group of substances that act on the same brain receptors as THC, the main psychoactive ingredient of cannabis. And some SCRAs also work on the other receptors. But they're commonly used by vulnerable groups such as homeless and prisoners, usually seen in those kind of groups. And because they're cheap and potent intoxicants. And unfortunately, they're absolutely unregulated. And they represent the largest group of substances monitored in Europe. And but there is little structural similarity between most SCRs and THC or other naturally occurring cannabinoids. And they're much more potent and toxic, potentially toxic than THC, do not contain cannabidiol, and the risk of developing psychosis is much, much higher. And the major SCRA groups, just for naming them, is HU series, CP series, and the JWH series. The SCRAs have, I haven't even gone into the details of these names, are associated with severe adverse reactions, serious toxicity, and death, and have been linked to bizarre behavior. For example, some headlines have screamed zombie-like behavior, stereotypical movements, and acute psychotic events, and even death. Synthetic cathinones are also amphetamine-type stimulants and have the effects that are broadly similar to both methamphetamines and MDMA, and again, constitute one of the largest groups of NPS detected globally, with 148 synthetic cathinones reported by the UNODC in 2017. Again, a staggering number. The most common synthetic cathinone is methadone, and it had made a comeback. It was used extensively in the late 90s, early 2000s, and then suddenly disappeared and keeps coming back and keeps going. And there are, of course, other synthetic cathinones. Methadone is the most famous. Again, they're markedly dynamic, with particular substances gaining or losing popularity. Generations have been developed, and they're typically in a powder, capsule, tablet, liquid, or crystal form, and consumed by swallowing or snorting, as well as injecting. And to complete the list, of course, and we can't go into details of every substance, as I said earlier, we have stimulants, we have depressant drugs, and we have hallucinogens. And some honorable mentions, just some plant-based substances too, we shouldn't forget them. This group consists of kratom, a plant indigenous to Southeast Asia, used commonly there, containing the alkaloid mitragynine, a stimulant at low doses and sedative at high doses. Kratom is used very extensively, found its way to the US too, and still not under legal control in the US. Therefore, it's been mixed with other substances, other street drugs. S. divinorum is a plant indigenous to the forest areas of Mexico, containing the active ingredient salvinorin A, which is a hallucinogenic substance, and it is used in religious practices and also as a medication in some of these tribes. Khat is a plant native of Africa and Arabian Peninsula, whose leaves are chewed, resulting in the release of stimulants, cathinonin and cathine, and they're used usually by the workers to improve their productivity during the seasons, and again used extensively. These are all traditional drugs which are used in these particular geographical areas, and of course they've been outlawed there. So no talk on street drugs can ever be complete with the exotic names, and actually all the drug users have got their own language, it seems, and they have exotic fancy names, some names which are depending on the local lingo, local cultural and local conditions. Of course, many of them to avoid detection by law agencies because they may be tracking them. So I mean, you can think of any name, and probably a drug will be named. A drug can be named with any of these fancy names. Sorry. So this, I'm not, of course, reading out each of these names. This is just to highlight what kind of glossary of names that we come across. So anything like oxycodone is called berries and blueberries, and imagine, or hydrocodone is called bananas. So I'm afraid, I mean, if you go to the US and ask for bananas, someone might just swoop down on you, thinking that it's a code for oxycodone. So that's the kind of language. There are, of course, some related terms. Designer drugs and club drugs. They're similar to street drugs. Designer drugs refers to drugs that are created in the laboratory and typically underground secret lab, created by changing the properties of a drug using chemical means. And the term club drug is a group of psychoactive active substances typically used by teenagers. So club drugs are those which are used in rave parties, bars, nightclubs, concerts, and parties. Of course, all these are diverse kinds of street drugs, and but they're used interchangeably in many conditions. So just to make us aware of this. So what are the clinical challenges we have with these newer substances that we encounter in the year 2021? First is the unknown substance at the time of clinical presentation. Virtually unable to detect in toxicology screens what the substance is. Due to the huge number of diverse substances, it's very difficult to develop tests or reagents to detect them. Lack of available testing, insufficient evidence on the potential harms. Uh, there is very scarce literature on these, insufficient evidence on clinical interventions, of course, and the rampant polydrug use. So these are the very specific clinical challenges that we have with these kind of chemical drugs which are produced in the laboratory. And of course, para on the role of the internet. The internet, both the darknet and the clearnet, is now occupying a growing role in the sale of drugs. I mean, the internet can teach you actually how to build a bomb. So why should drugs be behind? So they can actually tell you how to source chemicals. They can tell you how to actually synthesize them and market them, sell them. So the darknet markets are usually used for mild and low volume retail sales rather than wholesale sales to consumers, and sometimes, of course, acquired through social media. There are phone-based delivery services, apps too, like Ring and Bring, Dial a Drug, and even a process of Uberization, where most sellers provide fast delivery anywhere at any point of time. As I mean, see, when we order a Uber taxi, it comes within 2 to 3 minutes. That's how the uh, drug marketing network works. And of course, the newer challenge is payment through cryptocurrency, again, virtually undetectable. So what is the future? I just have a couple of slides. Henderson, way back about 25 years back, had actually predicted the future drugs of abuse will be synthetics rather than plant products. Obviously, it's much more difficult to grow hectares and hectares of plants with the vagaries of weather, pests, and quality of product, which can be varied across season to season, and plus the law enforcing agencies swooping down on you. It's much easier to produce synthetic drugs in a small laboratory all across the world. They will be synthesized from readily available chemicals, maybe derivatives of pharmaceuticals, will be very potent, and they will be marketed very cleverly. And this is, remember, before the advent of the internet, almost before the advent of the internet. The designer drug problem may become an international problem. A single gram of any potent drug could be synthesized in one location, transported to distribution sites worldwide, and then formulated into many thousand, perhaps a million doses. This, in a sense, summarizes what street drugs are today. So the model, what's happening, what's going to happen to the future, in the future. The model of producing legal alternatives to controlled substances are already spread. There is access to specialist knowledge. There are enough rogue chemists and dealers. Equipment is easily available, necessary chemicals too, means that synthetic drugs could become increasingly important and represent a serious threat. Second, they are highly potent as compared to what was available much earlier and as compared to plant-based drugs. And unfortunately, they are not identified in scientific literature. Third, the globalization will probably facilitate exploitation and regulatory frameworks. What happens? Politics, corruption, different regulatory frameworks, some allowing certain drugs, some disallowing certain drugs, some banning certain kinds of drugs, if not the whole class of drugs. The the drug marketeers and traffickers exploit these kind of jurisdictions to make their product available in these various countries. And fourth, internet will continue to support the rapid diffusion of substances into different settings in ways that will be very difficult to regulate and monitor. So Thomas De Quincey, who has been credited with introducing addiction literature to the West almost 200 years back, that is in 1821, wrote, and quite prophetic, I would say. Here was the secret of happiness, about which philosophers had disputed for so many ages, at once discovered. He was using opium both for medical and non-medical uses. Happiness might now be bought for a penny and carried in the waistcoat coat pocket. Portable ecstasies might be had corked up in a pint bottle, and peace of mind could be sent down by the mail. Thank you. Thank you. I finished my presentation.
Thank you.
Ashwin, can I ask one or two questions?
Yes.
Question.
You gave
And yes, sir.
you gave the 5 challenges.
Yes, sir.
In clinical practice, how to handle those challenges?
So these challenges are extremely difficult to handle, and as we have discussing before the presentation too. Most of the treatment management is symptomatic, based on probably what we think should be done and managing the patient based on our past experiences. And many of these drugs do not have very specific interventions. They don't have many specific treatment modalities which we can use. So we would probably have to go with the clinical presentation and the symptomatology with which the patient comes, and do the best that we can, because many of these drugs are unfortunately undetectable, especially in our country where the resources and our infrastructure is quite a few decades behind what is there in the US or Europe.
Should we have the second presentation now? And after that, we can have the questions perhaps. Dr. Amrit, what would you suggest? Should we have the second presentation by Dr. Debashish Ray?
So we can start with the next presentation, sir.
Yeah, I would suggest that let's have the second presentation, and then after that, Dr. Amrit can collect the questions and discuss. Okay.
Sure.
Good evening, everybody. Can you see my slides, the first slide? Is the first slide visible?
Yes, sir.
Okay. I feel greatly honored to be present over here. Thanks to Banai, a wonderful moderator, Amrit, Dr. Rajiv Gupta, and my mentor in my MBBS days, probably my best mentor in my MBBS days, Professor Debashish Basu. What I am supposed to talk about today is the management of cocaine dependence. There was an Inca proverb, an American Indian proverb, which said that if a white man takes coca, one day the white powder is going to destroy him. That white powder today, cocaine, has been the deadliest of all the street drugs. One second. And concerning all the substances, psychoactive substances, it's second only to heroin. Even in India, the prevalence of cocaine cocaine use vis-a-vis dependence has been increasing. As you can see here, that India has already much surpassed the general prevalence, the average prevalence of the Asian countries. So cocaine is basically derived from a plant called the erythrocylin coca. There's another plant of the erythrocylin genus. I've forgotten the name. So these are basically derived from the leaves of the plant. And people have been, in Peru, Bolivia, etc., they have been chewing these leaves for centuries, even before the advent of the Spanish invasion in South America. And they felt that it would be giving them a high, it would energize them, and it would also, it would improve their productivity, create a sense of euphoria. So this later, when the Spanish had gone over there, they used this so that they used this on the American Indians, the Incas, so that they could work much, so that they can be more productive. And later, what happened is, after the chewing, there was someone who had started the coca wine. Following that, there was this French wine called Mariani in France, even which had the Pope advertising for it. Soon we have this guy called Timberton in Georgia, probably, who put some sugar in sugar syrup and put cocaine and coffee, and Coca-Cola was born. So, and Coca-Cola was one of the top sellers during the Prohibition days in United States, like the Long Island iced tea. So later on, maybe around 3 or 4 years before people in the United States started shouting about cocaine, a Coca-Cola company had withdrawn the cocaine part from the Coca-Cola. Those days, cocaine was having a high medicinal property. It was used as in a lot of pain. It was used even topically. It was used even as an aphrodisiac. There are so many celebrities who are, who have been cocaine users. We have had so many deaths because of cocaine overdose in the American showbiz world. Sigmund Freud had mentioned cocaine in 12 instances in his writings. One of his friends in whom he had initiated cocaine had a cocaine dependence. Queen Victoria and William Churchill used to while their days sometimes, discussing about their common pain and, using cocaine together. So what is this cocaine? You see, there are 3 things over here. There are 3 colors, the red, the orange, and the dark one. It's basically, it is a benzoyl methyl group. Over here, you find the hydrophobic group. Here you have the hydrophilic group, the red one, and the orange one is the linkage. Essentially, it's an alkaloid of the tropane family. We know of a lot of other alkaloids like atropine, scopolamine, they also belong to the tropane family. So in spite of this hydrophilic phobic group, cocaine is essentially a hydrophilic molecule. It has a half-life of around oral cocaine has a half-life of maybe around the plasma half-life around 30 minutes, I would say. Dr. Basu would correct me. But the bioavailability of cocaine depends on how it has been used. Another interesting thing about the metabolism of cocaine is it is primarily metabolized, and in the liver, the plasma half-life is about 50 minutes. And benzoyl agocnin is the main metabolite, the essential metabolite which is found in the urine. And the enzyme which actually, one of the enzyme which hydrolyzes and deesterifies cocaine is also one of the major substrates in this dark arena of cocaine dependence psychopharmacology. A lot of people take alcohol with cocaine, and when alcohol is taken with cocaine, it's quite dangerous because cocaine gets metabolized to something called co-cathepsin, which is almost equipotent as a dopamine promoter, as as a dopamine transporter inhibitor, like cocaine, but it has got much more severe and much longer lasting side effects, cardiovascular and hemodynamic side effects particularly. So there are various forms of cocaine that we have. The interest is the powder cocaine, which is very expensive. I don't know exactly the price of cocaine in India, but what is happening is a free basing of cocaine, and what is usually consumed is this crack cocaine, with a lot of, you can engineer it at home. It's some sort of a home, you can engineer it. There are ways of engineering it. It's no rocket science to make crack cocaine from powder cocaine. And this, in tandem with the impurities that it has, creates a lot of hassles concerning the physical and the medical morbidities. So this is basically the biotransformation pathways. As I was telling you, the administration, the route of administration, determines the pharmacokinetics. Cocaine can be ingested orally. Coca leaf, which has hardly much of cocaine, the oral powder can be ingested. There may be intranasal cocaine. What you have, the snorting. The name crack has come because this sort of a sound that comes because of snorting cocaine. Intravenous cocaine, and also smoking of cocaine. It has entirely different pharmacokinetics, as you can see. Now, again, as you find that the onset of effects of cocaine in an individual depends on the admission, the route of admission. Similarly, how long the cocaine will stay in the effect is also depending on the route of administration. This is primarily a picture of what cocaine does. It's a schoolboy sort of a cartoon, which says that, which actually wants to indicate that cocaine would like to, inhibits dopamine transporters, very grossly saying, there are this D2, D1 transporters. There's some sort of an intricacy how cocaine behaves with each of them, but grossly saying cocaine inhibits the dopamine transporter and thereby prevents the dopamine reuptake, and thereby increases dopamine transmission in the synaptic cleft and gives rise to its desired high feeling and a lot of other other pharmacological activities. Similarly, there's also some serotonin dysregulation in the nucleus accumbens neuron, coupled with GABA modulation, which is also responsible for the cocaine dependence. This is what happens, once a person starts taking cocaine. The first thing, this is the other, there's this epigenetic neuroadaptation. After a person starts taking cocaine for a while, maybe for 10 days, and then he gets hooked onto it. He looks into he looks for the high, and sometimes, he needs increasing amounts of cocaine progressively to maintain the high. And this is the molecular basis of what happens. And all these, I'm showing this only to, these are the promising targets, the potential targets of possibly what we call a pharmacological cul-de-sac that we have concerning cocaine dependence. Is cocaine addictive? Does cocaine have withdrawal symptoms? A lot of people say that there's no dependence of cocaine because there is no physiological or physical signs of withdrawal. Now, we have talked about cocaine's tolerance. What about the reverse tolerance that cocaine causes and gives rise to a hallucinosis, gives rise to, not only paranoid psychosis, non-paranoid psychosis, hallucinosis per se, cocaine bug syndrome. So aren't these physical manifestations themselves? If we go beyond that debate, what we find is even in this, even the withdrawal that cocaine has established an evidence-based biological substrates. As you can see, sorry, the red lines, the full red lines, are the dopaminergic neurons. And the dotted red lines are the serotonergic neurons. The green line are the GABAergic neurons. All of this, they start addressing, this is the nucleus accumbens, which has got two parts. The inner part, the floor of the nucleus accumbens, where what happens is, when cocaine is introduced from outside, there's an increase in the availability of AMPA receptor in the neurons in the synaptic cleft of the nucleus accumbens. At the same time, there's a reduction of JLUR, repression of this gene, of this genome. So this definitely does prove beyond doubt that cocaine has, cocaine withdrawal is a syndrome. So this is also the abstinence syndrome in part, how it starts. The first day the crash cocaine is ingested, 9 hours to 12 days, you have, restlessness. Sometimes after the effect wears off, depression, late in the evening, maybe exhaustion. 1 to 10 weeks later, the withdrawal comes, even if you're taking cocaine in the same amount, and so on towards abstinence. So there's also, what we have is where is cocaine located in the brain? Again, an epigenetic hypothesis. What we have over here is there's a brain environment interaction where this HDC5, this is the cocaine-less nucleus accumbens. And this is the nucleus accumbens after cocaine has been introduced. So here it starts inhibiting, these genes start inhibiting, the transfer factors. And there's another gene called NPS4, which gets freed and gives rise to a lot more parallel genomes which induce neuroplasticity. And then there are much more synaptic connections which are caused. Paradoxically, I do not know how, in spite of this substrate, in spite of this happening in the, in the microneurobiology, why does cocaine still have cognitive impairment after chronic use? That may be a different explanation whatsoever. Females have to be more sensitive than males in with cocaine, primarily because estrogen enhances the glutamatergic genes, and also, estrogen also starts teasing the cannabinoid signaling pathways, urging them to enjoy the high, to create the high. And later on, when there is, when there is, dearth of cocaine relatively quantitatively or absolutely, females are found to be more affected. Cocaine dependence. What is cocaine dependence? There have been a tremendous, there has been a significant difference in how, in the language used concerning cocaine use in both ICD-11 and DSM-5. It has been very, very eloquently described in Professor Basu, one of the articles of Professor Basu, when the ICD-11 draft was released. ICD-11 actually retains the term cocaine dependence, giving rise to a wider pharmacological spectrum, whereas DSM doesn't have any term called cocaine dependence. ICD defines it as a strong internal drive after repeated or continuous use, with a subjective sense of craving, almost on the lines of the Edwards and Gross criteria. Then you have the physiological features of dependence, and defines a time period of at least 1 month of continuous use. DSM has probably, DSM-5 has shifted from the hierarchical approach to the dimensional approach and has done away with cocaine use, cocaine dependence, the concept, the term. Usually what happens across the world, people start using cocaine when they're 23 to 25 years old. Within the first year, 5 to 6% become dependent. And within 10 years, another 15 to 16% of users become dependent. So how would we manage cocaine dependence? We have to know that cocaine dependence is severe. What are the challenges that we have? We can bring the patient to you, to ourselves. The patient is quite reluctant to come. Even if he comes, he is quite reluctant, recalcitrant to continue the treatment. So the first challenge is definitely, continuation of the treatment. The second is the severity of the relapse. Even then, the dependence is treatable. Treatment has to be personalized. And during the course of treatment, you have to continually assess your plan, reassess your plan, and modify it according to the need of the of the patient, according to the time frame that the patient is passing through, the social milieu, the physical status, etc. And what is vital is, it's been seen that once a person sticks to the treatment for more than for 3 months or more, the outcome is much more improved than otherwise. So these are basically the components that we have. It's not only pharmacology, but entirely a multidisciplinary approach that we have. As I've told you, how to diagnose it. When a person comes to your clinic, what is very important in the psychiatric examination, apart from using the rating scales like addiction severity index and CASS, etc., is the history has to be proper. Sometimes the history that you get from the patient has to be, corroborated by another informant. The patient may start, giving a different account of the amount, duration, and the difficulties that he has been having. So the dependent severity has to be assessed. This is very important. It has got a prognostic significance. And the motivation, as with other substances, that also has to be assessed. Physical examination, as you know, cocaine is an indirect sympathomimetic, so it cocaine use actually hikes up all the parameters. So in case of a cocaine withdrawal, you have bradycardia, and bradycardia is one of the reliable indicators of cocaine withdrawal. You see the BP, both the systolic and the diastolics are raised, body temperature is raised. ECG is important because of the fact that cocaine gives rise to a lot of cardiac hassles, primarily myocardial infarction, even in people who don't have any cardiometabolic abnormality. And though what we see is what is advocated in acute cocaine intoxication, labetalol has been, quite well advocated. Please do not use any beta blocker when the patient has a cardiac morbidity or when the patient has a suggestion of a cardiac morbidity. Lab, the urine, which has a false, amoxicillin. When a person keeps on taking amoxicillin, there may be a false positive result. Hair, rarely used. There's some talks about a fingerprint biomarker in maybe a couple of articles. So this is the scale that we were talking about, which is very important in terms of, assessing assessing the severity of cocaine dependence, assessing the prognosis. It's basically an 18-item scale, which can be which can be easily administered, but it has to be administered with a clinician, in presence of a clinician. So it has got 7 points, 18-item scale, which is which is highly indicative. Not only it does give measure the severity of the dependence at the index interview, it also helps to identify what we call the B-type cocaine abusers or dependents, people who have comorbid depression, people who have even other factors which may be negative predictive factors in case of cocaine dependence recovery. Groups of medication, this is very basically a gross thing, which I do not personally subscribe to this classification of anticonvulsants, antidepressants, etc. So we'll come to that. So concerning antidepressants, what we see is that when acute administration of cocaine actually hikes up all the monoamines, dopamine, norepinephrine, serotonin, while chronic use of cocaine down-regulates the monoamines. So this interested a lot of guys to start looking and investigating antidepressants in cocaine management. What they found, what was primarily, these are the primary, desipramine, which is not available in India, fluoxetine and bupropion was mainly investigated. There was no change in the primary outcome measures like abstinence, like reduction of cocaine use, adverse effects, etc. The only positive results were with mood-related outcomes. If there's a person with cocaine withdrawal may start not feeling the high, maybe may start missing that high, and so this might sometimes, help him to an extent. May not be clinically, but there were only mood-related outcomes had improved, except for one study which showed, again, very paradoxically, Dr. Basu would be able to opine about this, that fluoxetine has been found to reduce cocaine use in non-depressed subjects. I don't know the mechanism behind this. And SSRI, fluoxetine, one of the prototype of SSRIs has been found when it's used in non-depressed subjects, but when fluoxetine was used in cocaine-dependent depressed individuals, it did not reduce cocaine use significantly. Antipsychotics, as you know, they block the dopamine transmission, and at the same time, they are serotonin modulators. You have these molecules which are called dopamine system stabilizers, etc. But even then, only 8 out of 14 studies showed some sort of a non-significant dropout rate. In another study, risperidone reduced the dropout rate significantly. That was in 2012. Dopamine agonists, as you know, they increase the mesolimbic dopamine, and thereby they reduce craving. Per person with cocaine withdrawal, what have been investigated have been levodopa, carbidopa, pramipexole, cabergoline, ropinirole. So what has been found in 24 studies, including about almost 2,500 patients, there was no improvement in any outcome. Psychostimulants, it's almost like a substitution therapy, like we have the methadone substitution, etc. So what is basically done is you tweak the nucleus accumbens, the mesolimbic tracts, etc., by replacing cocaine with something with a similar mechanism of action of cocaine, but with a much longer acting. So, for example, dexamphetamine sustained release, etc. Bupropion, which has been touted as a psychostimulant by some, is found to have prolonged abstinence, as with dexamphetamine sustained release. Modafinil in some studies have shown to reduce the number of days of cocaine use. I stand to be corrected, but probably modafinil has been the only psychoactive substance which is established, which has got a significant effect in reducing the number of days of cocaine use. Disulfiram, as you know, disulfiram has been approved in alcohol dependence, and as no drug has been approved by the FDA in cocaine management, disulfiram is also not there, but disulfiram has a broad spectrum enzyme inhibiting activity. In that way, it also enzymes dopamine beta hydroxylase, causes, when there's a sustained abstinence, disulfiram actually hikes it up, and it has also found to reduce cocaine use. These are the GABA mimetics by baclofen, very doubtful. 60 milligrams a day. Again, I do not know how many of our Indian practitioners would prescribe 60 milligrams a day of baclofen, especially in the metropolis. Thiogabine was found to reduce cocaine use. Interestingly, progesterone, which is also actually a GABA mimetic, it was found when it was used in 200 milligrams a day, it reduced the diastolic BP of cocaine withdrawal subjects, did not change the systolic BP. And it also, reduced the craving for the subjective high. Again, this is something like the opioid agonist theme, where bupropion, naloxone, methadone, and probably, arguably, naltrexone has also been tried in this cul-de-sac world of cocaine psychopharmacotherapy. There are various other molecules, including targets which satisfy the kappa receptors. So I don't know much about this ecopipam and adrogalite, but there are plenty of other molecules, and this may whatever has been tried. So this is what we have in psychopharmacotherapy. Now, who are the people? This is one of the interesting studies which was conducted in Canada. This was a study where pharmacotherapy was continued for 12 weeks as an add-on to cognitive behavior therapy. Cognitive behavior therapy specified for cocaine dependence, where topiramate, modafinil, and this dexamphetamine SR, again a stimulant with a long-acting SR. The study is still underway with a lot of limbs. We haven't had the complete report yet. Is comorbid personality disorder, does it augur badly in psychopharmacotherapy of cocaine dependence? What we have found is when cocaine dependence is comorbid with type B personality disorder, these cocaine users have larger caudate nucleus volumes than cocaine users, cocaine dependent patients without any personality disorder. And then there's also thinning in the lateral orbitofrontal cortex of these people with cocaine dependence and personality disorder type B than even persons with cocaine dependence and personality disorder type C. This is also very interesting. Non-pharmacological management, I'm not going into details about that. Psychotherapy, that is cognitive behavior therapy. Contingency management, some either alone or with psychotherapy or with CBT or with pharmacotherapy. And then motivation enhancement therapy as usual. Neuromodulation, RTMS has been found to have some role. Auricular acupuncture, probably ancient. I don't know. Some ancient reports are there of hypnosis, and there are these self-help groups like the Cocaine Anonymous. So where do we go from here? There are some studies about machine learning being instrumental in the management of cocaine dependence. This is just a very simple chart which shows on the yellow you have these, the yellow square, the orange squares you have the frontoparietal and the medial frontal. These are the controlling squares, whereas the green squares are the activating squares. In fact, there's a differential D2 and D1 receptor systems, in which there's a subtle balance which causes intoxication in some individuals, causes dependence in other individuals, and causes, and probably with some genomic mediation, causes, hastens dependence in other individuals. Efforts are also now on to find out the biomarkers of cocaine dependence. This is just a chart to show, and every type of biomarkers, in all the 5 classifications have been trying, there are putative biomarkers in almost all the classifications of that biomarkers have concerning cocaine dependence. One of the future over here, as we are quite helpless concerning the cocaine psychopharmacotherapy in general, there's a lot of cocaine vaccines, not vaccine, but vaccines which have been talked about. One of the hassles with vaccinating cocaine is the smallness of the size of the cocaine molecule. But even then, what happens is when there's an antibody which is formed with this vaccine, what happens is the euphoric, the pharmacological effects that actually hones an individual towards dependence, hones an individual towards sustained abuse, is nullified or at least significantly attenuated. Summary, there's still now no approved pharmacotherapy. Not only that, I do not think there's any significantly, significant pharmacological agent which we can look up to. There have been some talks about topiramate. Probably the best bet would be CBT plus pharmacotherapy conjointly with contingency management, but management has always to be personalized, and personalized management has to be repersonalized, if I can use the word, during the course of management of cocaine dependence, be it for 7 days, be it for 3 weeks, whatever. And we have to have a careful monitoring of the medical morbidity concerning the serious hemodynamic and the cardiovascular effects that cocaine has, and the psychiatric morbidity, which sometimes may actually hinder proper recovery from cocaine dependence. All I knew before I was asked to, present this about 2 days ago, my cocaine was Eric Clapton. This was the song that Eric Clapton had composed when he had just quit both cocaine and marijuana, but he was very high on, alcohol, which again had taken a lot of time for him to, kick. Thank you very much.
Thank you so much, sir. For a wonderful presentation. If the chairpersons permit me, I'll take the question, sir.
Yes. Yes,
Sure,
please.
sir. Sure.
So here is one question. The first question is for both the speakers, actually. So a question is from Madhav Raj. Why is it not appropriate to diagnose delirium when an addict suffers from confused state of mind as a result of overuse of alcohol and cocaine taken simultaneously? I don't understand the question, actually. So can I repeat the questions, or you got the question?
Yeah. Dr. Mohan, will you answer?
Delirium is a very generic condition, actually, and delirium can be caused due to any particular reason. And many of these intoxications can lead actually to delirium. So if the signs and the symptoms of delirium are present, one can diagnose it as a person being delirious during the process of intoxication itself. So I think loss of consciousness, change in consciousness and specifically other issues may contribute to delirium during the period of intoxication too. So I think it's really I don't know how important it is to diagnose delirium at that point of time, whether it's only intoxication or delirium. But in any case, one has to manage depending on the signs and symptoms and the presentation.
Can I add something?
Yes.
So please.
So definitely, when some conjoint use or abuse of cocaine and alcohol does produce delirium, I do not know whether you're actually alluding to the diagnostic criteria's lingo when they say that in the last few one of the last clauses, which says that not due to any other substance, etc. But cocaine per se, cocaine alone has been known to cause acute confusional state, sometimes bordering on delirium, and cocaine and alcohol conjointly can definitely give rise to a severe metabolic imbalance, which does cause what we define as delirium.
Thank you, sir. Dr. Ashwin, the next question is for you. We'll be a little fast because there are a lot of questions.
Yeah.
So, is there any site where, as a common practitioner, as a common private practitioner, we don't know about the novel psychoactive substances? Is there any site where we can actually, get our knowledge, where we can know about what are available?
Oh, there's huge amount of literature on NPS and easily available on the net. In fact, some of the established sites include the UNODC and of course ECMD DA, that is European Monitoring Center. I've forgotten the full form, but in fact, NPS is much more common in Europe, and they have an extensive literature and detailed manuals and detailed data, detailed issues regarding clinical presentation. In fact, there are a couple of good books too, in clinical books, and I can send them to that person if he messages me. Some on NPS specifically, some on club drugs and management of these issues. In fact, there are people who are trying to develop guidelines, clinical guidelines for the treatment of many of these persons having dependence or abusing NPS. So there's a huge amount of literature easily available on the net. But if someone wants them specifically, they can.
So will it be okay if you can just type in the chat box and we can send it to them, sir? Or you want us to mail it, sir?
Yeah, it's best because I don't remember offhand all of them.
Sure.
So,
thank you, sir. Dr. Rai, Ray, sir. So, what is your take on gabapentin being used for treating cocaine withdrawal with comorbid depression and somatization, sir?
No, I don't know. I'm not aware of any study with gabapentin being used and in a person with comorbid depression. There's no solitary study or, but gabapentin has not been found to significantly improve the comorbid depression in, in cocaine dependence. Somatization has not been reported either as a solitary symptom of cocaine dependence or as, as an analog of both cocaine dependence and comorbid depression. This may be, again, another offshoot, and I am not aware of any study. I would not use gabapentin in cocaine dependence with somatization and depression.
Sir, thank you, sir.
So I'll just 1 second, Amrit. I'll just add. I think we have an Indian book on clinical substance abuse edited by Dr. Basu himself, and two excellent clinical guidelines published in I think 2014 and 2015, if I'm not wrong. Sir can correct me. And they are available on the IPS website. So I think that's a very good place to start.
If Dr. Basu can add, sir.
Yes. Yes, yes, it's freely available. There are 3 volumes of which are freely available PDF from the Indian Journal of Indian Psychiatric Journal, Indian Journal of Psychiatry website.
IJP.
Yeah,
IJP website. Yes.
the IJP, the
IJP, sir.
Indian Psychiatry Online. Go
Sir.
to the left-hand side panel, go to the lower left side, there will be a series of clinical practice guidelines.
Yes, yes.
There are many of them. 3 relate to specifically to addictive disorders. That was the time when I was the convener of the addictive disorders section, and Professor P.K. Dalal was the chairperson. So we took out 3 books written by all very eminent people all over India, and one of them, the 2016 volume, specifically has chapters on newer psychoactive substances, cocaine, stimulants, and all these that we are talking about today. That was 2016, but and it required some updation. But obviously, we don't have any further approved drugs as yet. So, as Ashwin said, that's a very good place to start. Thank you, and they are freely available.
Thank you so much, sir. Dr. Ashwin, the next question is regarding street drugs. Mixing and cutting is common, and this will complicate the presentation. This will also apply for novel substances. If so, if we go by treating symptomatically, what pointers should we keep in mind? Because there are a lot of mixing and cutting when these drugs.
Okay, I specifically did not add adulterants or cutting agents
Yes,
during my
yes.
presentation. In 20 minutes, it was virtually impossible to deal with all of these. But yes, cutting, there has been detailed analysis of what cutting agents are being used both in the US and Europe. And you will be shocked to believe that we have antidepressants, benzodiazepines, of course. We have even have olanzapine, clozapine, and many other such psychotropic drugs that we use usually in our clinical practice, which have been detected, and which includes, in fact, chalk powder, right from chalk powder to insecticide to, I mean, you name it and it's there. I mean, people can mix anything with anything else and sell it, as long as it can actually, one, increase their profits, two, provide a kick, enhanced intoxication, and of course the resultant toxicity is always there, and really nobody cares about it. So there are huge numbers of, in fact, I've actually gone through a book where there is a detailed analysis of cutting agents which are there, and so it makes for fascinating reading.
So it's tough and difficult, and sometimes it's hard. Sir, Dr. Ray, the next question is for you, sir. So there are 3 parts actually. What is the genetic basis of cocaine addiction? We can be very short on that. Is it simply accidental due to club culture or a strong genetic loading behind it? If so, can we predict the possibility of cocaine addiction in all alcoholics practically?
I'll start with the last question. No. The genome of even the epigenetics and even the genome of cocaine dependence is different from the genome of alcohol abusers or users, though alcohol and cocaine has been used simultaneously. There have been a lot of genetic endowment, as I was, even the cocaine environment interaction that is genetically endowed, but how much of this is vertically transmitted across generations probably has not been studied. But there has also been genetic targets uh, concerning the pharmacotherapy of cocaine dependence. So genetics as a causation of cocaine dependence, there are genes which have been found, there have been therapeutic substrates which have been identified, but I do not think there's any a person with alcohol dependence or abuse will be uh, more vulnerable towards cocaine dependence than a person who doesn't use or who doesn't abuse alcohol.
Thank you, sir. There are a few interesting questions that have just come out. They're the recent questions, sir. So 1 or 2 questions will be common to both of you, sir. So the first question is, what is the essence of removal of terms harmful use and dependence to just use disorder in DSM-5?
Dependence probably what there has been a lot of gray areas about what dependence in various substances. Dr. Basu would be a much better person to answer that. There have been debates about whether you have a marijuana dependence or not. We have had debates about marijuana legalization. Similar, so this, when they are doing away with dependence, one of the things is to subvert this sort of dilemma. But primarily when the task force, there have been when the DSM-5 task force was there, when they had set, when they were sitting together, the primary reason of doing away with the term dependence, the primary reason of, with the, even not only the term, the construct dependence is towards going more towards a dimensional approach. Instead of maybe give 1, 2, 3, 4 criteria and maybe a time frame of 3 weeks or 2 months, and limit limit a user, or probably not underdiagnosing a cocaine dependent person, though there have been, people have said that there have been risks of overdiagnosing dependence with the current DSM-5.
Thank you, sir. Ashwin boss, your take on it. Quick take on
actually, I would just add a couple of things. One is that all these different substances have different clinical presentations, one, and of course, all the criteria will not fit. For example, some substances will have cravings, some may not have, and many of these criteria are not very well defined. Second, of course, as he said, it's a dimensional approach. It's a more inclusive term where we can actually include more people and bring them under the umbrella of treatment, rather than just bringing a particular category of certain people.
Dr. Basu, sir, will you add something to it, sir? So you're in mute mode, sir. Please unmute mute.
Yeah. I mean, because we are running very short of time. So other than what has already been said, the primary reason was that dependence can be pharmacological dependence, and it was a stigmatizing term because a person can be completely dependent pharmacologically or physiologically. For example, a person who has cancer and metastasis and is on morphine will develop tolerance and withdrawal. So will be dependent in the physiological or pharmacological sense, but he will not be addicted to the thing, because addiction or substance use disorder is more than only cellular tolerance and physiological withdrawal. It is a complex of behavioral, motivational, cognitive, and then cognitive changes, the whole complex. Hence, they decided to do away with the term dependence as such. But of course, ICD-11 has decided to keep it.
Thank you, sir. Dr. Gupta, sir, I'll ask you a question after I ask a question to the speakers. It's an interesting question for you. Can treatment of drug de-addiction be forced in an unwilling drug addict? If forced treatment is instituted, in what percentage of cases it is successful? So I'll come to you after the speaker speaks. So Dr. Ray, sir.
Yes, concerning
forced de-addiction.
Concerning cocaine dependence, yes. Sometimes you have to, sometimes voluntary treatment carries a worse prognosis than, coerced treatment. I won't say forced treatment. So, because the extent of craving that this cocaine abuser has will probably deter him from going into the treatment. There are a lot of, as Professor Basu was telling, there are a lot of these other psychological associations, socio-psychological associations, which probably deter, and a person with cocaine abuse or cocaine dependence seek treatment and to maintain treatment. So forced treatment sometimes is, advised internationally. Though the inpatient treatment of cocaine doesn't have much scope, and there's some researchers say that there's no need of any inpatient treatment. I don't know about the percentage part.
Thank you, sir. Dr. Ashwin Boss, your take on this.
I have a different take on that. Coerced treatment I don't agree with it really because ethically, I mean,
Yes.
clinically we understand it, morally we might understand it, but ethically it is not correct. And uh, just because you, unless of course he fulfills certain criteria, for example, harm to self, harm to the others, or getting, or he is forced by the court to undergo treatment or something like that, coerced treatment itself is not enough, and it may or may not work. Percentage wise, actually, is very, very difficult to say, and it has no meaning really whether a person who's coerced into treatment will be better off or who is coming voluntarily for treatment, because the treatment outcomes definitely depend on so many different factors, and this may or may not play a role. But I'm definitely against coerced treatment.
Gupta sir, so your take on this in your clinical practice. Let
Yeah.
us forget the ethics. Let us look at the percentage. Is there any
Same,
justice?
same clinical practice is not possible. It's not practical to enforce a treatment on a heroin addict or a cocaine addict or any other addict. So one, the person has to be motivated to leave the drug. And second, under the new act of the Mental Health Care Act, is not practical unless there are given situations, particular situations, and those situations are not very common. So in majority of the cases, it is practically impractical to force a proper treatment to a drug addict.
Thanks. Dr. Basu sir, your take, and then we'll take the last question because we're already running short of time.
I think it has already been said. I mean, there are times when you do come under the pressure for treating somebody involuntarily, but it never works. Full stop. Any involuntary treatment, I'm yet to see a single person in my 35 or something like that years of practice, 34, who has actually benefited from a forced treatment. The rule is that the person will relapse after that. So, and then the other human, other rights issues, etc. I'm not even going there, but for the purely pragmatic reason that it will not work. He will hit the TECA or he will go to the drug den the day he is released from there. This is what exactly happens for most of the other people who are lodged in prisons, for example, So it simply does not work that way. A much better would be the question number 4 there in that yellow highlight, which Amrit you have, and if you may ask that will come to the right perspective probably for the thing. There's a question number 4 which I have mentioned to you. If you can please read it out.
Sir, application of concept of harm reduction.
Yes.
For
Please.
street drugs, considering difficulty in implication of legal arena, not being able to curb its use as predicted in future direction. The fourth question, sir.
Yes. I think let there be some response to that from Dr. Ashwin and Dr. Debashish, if needed, because I think that's something which is directly relevant here.
Will I repeat the question, Dr. Ashwin?
Yeah.
Application of concept of harm reduction for street drugs, considering difficulty in implication of legal arena, not being able to curb its use as predicted in future direction.
So, okay. Now, I'll just take 2 minutes. No, we're already beyond time, just 2 minutes. Harm reduction itself involves a huge gamut of interventions. It is not just substitution therapy or providing a controlled substance in a controlled environment. That is only one aspect of it. And there are many other different aspects, right from reducing the physical and psychological harms, providing the tools or interventions, for example, syringes, etc., providing a safer environment for the patients where they can use the drugs. So all that depends on a very, very important thing, which is the jurisdiction and politics of a particular area. And there are many areas. For example, we know of, I'll just take example of injectable heroin in Sweden or Germany, where they provide safe areas where you can inject heroin and you can inject inject heroin and given syringes, but they are for a very, very small percentage of patients who are not able to give up their dependence on heroin. Now for NPS, we must understand, firstly, there is very little literature available on the dependence potential of these NPS, one. Two, the very little literature available on the clinical presentations, what kind of patients are there, how long they use it. So there is very little literature to support one. Secondly, the kind of interventions and whether we have tools for these. So whether if the question is directed at asking, can we or the government or any kind of jurisdiction provide these substances in a regulated manner, in a pure manner, with potency which is controlled, so that these people can use and thus they can be safe from toxicity, is part of a much larger question. And really, I think if I talk as a liberal, then yes, it is possible, but practically, I am sure that this is not going to happen. I mean, that is the only thing I can say in a short period of time, but of course, there are many dimensions to it.
Thank you so much, sir. Sir, do we take it as the last question? One word only, sir. Is decriminalization of drug use a utopian goal in the world in this decade? Yes or no?
Will you please
Dr.
come
Rai,
again?
sir.
Will you please come again?
Is decriminalization of drug use a utopian goal in the world in this decade? Decriminalization of drugs.
It's a very small question which needs a large answer.
We just take a yes, no, sir, because already running time, and
I would say
asked
no.
Dr. Thanks. Ashwin boss,
I would
you
say
are
yes, actually. Yes.
No, it's not a utopian. It's not a utopian goal.
Dr. Ashwin is
because utopian goal is something which is utopia is something which I think no one can achieve. So it's not a utopian goal. It can be achieved in very.
In this
so
decade?
I mean, I can't answer that question more. I mean, but more than this.
Very, very relative.
Yes, it's a very difficult question to answer. But in
Thank
one
you.
word, no.
Thank you, sir. Thank you, Dr. Rai and Dr. Ashwin. Over to the chairperson, sir. We couldn't cover all the questions, but then we tried our best, sir.
Yeah, I think I'll give the chair the privilege to Dr. Rajiv Gupta, my senior, and with a tremendous amount of practical experience. So let him speak. Okay, I keep on speaking here, there, and everywhere. So, but I liked it. I enjoyed it thoroughly. Dr. Rajiv Gupta, please.
Thank you so much, sir. So I think we had a great talks, both of them. And as a practitioner, one, you get sensitized because you come to know, you understand what are the newer things happening in your field. And particularly the drug abuse, by and large, affects the youth of our country. And young people are predominantly the major population of any clinic. So it is quite a challenging experience, and treating them day by day, day after day, I think challenge is increasing. And what I learned from the two presentation was that in academic circle, particularly people who are in private practicing, particularly their assessment tools and their treatment tools, I think they are lagging behind than the kind of the drugs used by the drug addicts. I think it's like a thief and police game. The police is always later than whenever the crime has happened. So I think there's a lot of lessons to learn from these two talks. And I must thank the Banai Group for this presentation. And thanks to the speakers.
Yeah, thank you.
Thank you so much. And now the most interesting part of the whole program, the best question award. And Dr. Rajiv Gupta, being a senior person, he excused himself from the decision making. And Dr. Devasis Basu, who chose the best question, goes to the question number 4, which Dr. Basu told me to ask, by Dr. Niska Sinha. That is application of concept of harm reduction for street drugs, considering difficulty in implication of legal arena, not being able to curb its use as predicted in future direction. So she wins an Amazon best question reward of 5,000 rupees. So thank you, chairperson, speakers, Banai Group, and all the audience was. There were some beautiful questions, but then the best was chosen by Dr. Devasis sir. Congratulations to the winner. Thank you so much.
Yes, congratulations. Thank you. There were nice questions, but then we have to choose one, of course. And this is something which doesn't have an answer, but something which makes you think, that's why I choose. Thank you.
We thank you all for joining us today. We hope to see you again soon. Please block your date for Tuesday, 27th April 2021, same time from 8 p.m. to 9:30 p.m. Also, based on many requests that we have received, we would like to inform you all that all our previous webinar archives are now available on our YouTube channel, Banai India. Do send us your feedback and comments, if any, on info@banai.org.in. Till then, stay safe. Good night.